Thanks for coming back for lunch. We actually have a really interesting panel today. We have Mario Silva from University of Parma, and we have Artit Geratnikol from Mount Sinai, and we have Ella Kazruni from University of Michigan. And we're going to be looking at this question of what's the best place for AI development to spend their resources. So what I've asked is that the panelists all consider, actually the slides. I've asked everybody to think about this in terms of the pipeline, let's say risk assessment for lung cancer screening, detection, differential diagnosis, meaning you've got, let's say, 2 time points and you want to know whether or not it's growing or some other way, therapy, and then patient communication. We discussed large language models last time. And I asked everybody to fill out this scorecard with where, if they had the ability to apply billions, hundreds of billions of dollars, where would you put the emphasis to have an impact in the next 3 to 5 years? And so, which is kind of no small task. And then we asked David to give the introduction to this whole question. And so I'd like to turn it over to David and let David tell us how the world looks.
The world according to David. Well, I'll do my best. So we have the slides. Okay, so I'll be talking a little bit about AI and lung cancer screening. Next slide. I'm going to go pretty fast through these. Next, yeah, those are disclosures. So just a sort of a broad statement. AI will be used in all aspects of screening. And I think everybody understands that. It is relentless in terms of it just continues to get better. And all of us have seen improvements over the years in every aspect. Next. So when I think about the lung cancer screening process, I thought I could break it down into sort of the area of risk assessment, screening, and treatment. Although another way of thinking about this might actually be screening. You really want to be inclusive, includes all of that. The whole screening process should be from who to screen to literally the whole gamut of treatment. But more narrowly, we can think of the screening as just the sort of the imaging side of it. And let's just focus on that. Next. So let's think about nodule detection, growth assessment, maybe nodule characterization as the kind of the core aspects what people are focusing these days on software development. Next. And my point about all of these is that, in my view, it seems that the techniques for how we analyze this data are already there. The AI is very good, and what's missing is not so much the AI development, it's the data. With enough data, I think the problems really can be solved. The AI is that good that I think we can really turn our attention more to getting great data. And, this is just, the simple example of diabetic retinopathy is a good one. 128,000 retinal images. And, to scan the retina and look for something is a hell of a lot easier than looking at a CT scan. It just is. And look how many data points they use. 50 ophthalmologists, 128,000 retinal images. That's how they got primary read. All of this is heading in that direction. We have nothing like that in imaging. Next. This is, I borrowed this from Artit. He gave this presentation. Most of the AI that's been developed in lung cancer, they use the LIDC database or the NLST data. This is old data. This is 15 years old. And Artit took a look at the NLST data, and he found that 85 or 90% of the the scans done in the NLST had slice thickness bigger than 1.25 millimeters. That doesn't meet anybody's standard anymore for what we should be doing in lung cancer screening. And yet virtually every product out there is built on this, including characterization, et cetera. So this was just on slice thickness alone, the vast majority is ruled out. Next. And then if you look at just the edge, of the kernel, the reconstruction kernels, most of it was used edge enhancing kernels. And then there was a bunch of scanners that had spatial warping, which nobody would use for things like volumetric assessment. So that data, you really can't rely on to do, what I think would be modern, AI that's really going to be developed, that's going to change the world. It's not going to happen with that data. So our focus needs to be on getting these massive databases, where we can really train the AI. Next. And this just shows that there's only a small, once you get to that very small number of cases that actually have good enough scans, the number of cancers gets down to be a very small number. Next. In terms of detection, there's second read, there's concurrent read, there's primary read. I'm not going to go into this in much detail other than to say that the dream is primary read. But I will also say that the software is really good in this area. Already the detection software, even before AI, the detection techniques using traditional methods for evaluating was already getting very good at finding lung nodules. And now it's outstanding, really, in terms of finding the small lung nodules. It does very well. And there's differences a little bit between, and people want to keep reducing the number of false positives and all that. And that will continue to get better. We need bigger databases, et cetera, et cetera. But I feel that aspect of things is very much there. And even when you read the scans and you have an AI system, you can go through it pretty quickly to see the extra nodules. It helps you find additional nodules, especially small ones. Next. And it's even getting good at things like this. You see what I'm pointing to? In the past, things like that were in the hilar region were often missed. Now they're starting to find them. Next. There it was a year ago, it was gone. You didn't see it a year prior. And next, and you can just to show you the AI, you can see it circling it. It's finding all the lobes, tells you what lobe it's in, can tell you, it segmented it very nicely in the red outline. So it's getting good. It still struggles a little bit with the hilar area and things like that, but it just continues, as I say, to get better. Next. And the question, I think, becomes, it's good at finding nodules like this. It's really good at it. And the question is, how much better does it have to get? Do we need to find smaller nodules than this? I mean, we're really we're getting to the point of diminishing returns with CT imaging. We're finding all the 6 millimeter and 5 millimeter nodules. When you start looking at the cure rates of these 5 and 6 millimeter nodules, it's 90%, 95%. I mean, it's great. We could get to this point, we would change the whole face of lung cancer. So we're getting to the point of diminishing returns, at least in terms of detecting. And next, and I'm just showing here that we can, these can be diagnosed. We can, you can biopsy them, you can treat them exceptionally well. Next. Just a comment, I think one of the areas where AI is going to have a really important effect, especially when you go to low-income countries, I think the chest X-ray is going to need to be looked at again in a much more serious way. I think chest X-ray evaluation is going to be, if you think globally, it's going to be the primary method of screening. I think there's a huge benefit that we have all overlooked in chest X-ray screening, but that's just my editorializing. Next. In terms of where I think there's still a lot of room for improvement, and I think is going to have enormous impact, is how we evaluate change over time and how this is looked at. 1956, which was a very good year for some of us. The definition of this is the observation on growth rates on human tumors. This was by Collins. And he wrote this: the definition of cancer, its diagnosis and prognosis all depend on descriptions of growth. To a layman, a synonym for cancer is growth. Really an amazing statement. Next. This was the paper that Claudia wrote on LCAP. It came out in '99. And that was the next slide. It reached the front page of the New York Times. And if you look at that front page of the New York Times, next slide, this is what they said. Study shows routine x-rays have failed to find growths. It's all about growth. That's what the point was. And when you think of cancer, you really have to think. And that's why I think the ability to measure growth and change is absolutely fundamental to what cancer is and how we should define things being cancer. Something is cancer and it doesn't grow, not really cancer. It certainly doesn't behave like it in the overwhelming majority of cases. Next. And looking at growth, I've shown this slide many times. You just look at the image, it's compelling. Next. These are the 3D representations of the same nodule. This was, I forgot, 1 month apart. This was, as you can imagine, a fast-growing cancer. And it's convincing. You see these pictures, viscerally, you're convinced that this is a wonderful technique. But next, yeah, you can do all kinds of wonderful things and look at the vessels attaching to it, and you can see the surrounding parenchyma. This area continues to be explored. Next. And growth is used in everything. These are just different protocols. And you can see that everything in orange and green, or orange and yellow, require follow-up where you're looking for, these are the different, every protocol relies on growth, especially for the small nodules. Growth is the primary way. And how do we go about measuring growth? Next. I just want to show you that it is not a simple thing. This is a case of a nodule that was scanned, in this case, 4 times. In the same sitting. This is a patient that's on the table. We didn't have the patient get off the table. We practiced the breathing ahead of time. We used a high-quality scan technique, thin sections. We measured it, and the volume difference between each of the 4 times, a relative difference in the volume measurements of 36%. It was a maximum 36% difference in the volume measurement. It's a big amount. That's a big amount. It's a little scary, actually. Next, I'll just give you a few examples. Here's another one. Scan that nodule, in this case, 5 times. This one had a 30% variability in the measurements. And you can't get a more ideal situation. You can't get a more ideal situation than the one I present here. Patient's not getting off the table. The scan is obtained 1 minute later, thin sections. So this is next.
Is that mainly because of the breath? The breathing?
You can't get a better breath hold than I taught them. I literally practiced the breathing with them.
Yes,
Literally
but that
practice.
could still be a major contributor.
It could be, and there's many things that can contribute to this, and we'll get to that. Here's another one, though. This one is what you dream of. This is a more peripheral one. This was a 2% difference. Now you're talking. I have several hundred of these cases, which somebody in this room who's an expert in metrology is going to help me analyze.
My goodness.
Now you get it.
Mountain come to
Now you
valley.
get it. So this is, to me, a fascinating topic. Next. Current reality, even under the best scenarios, using the same measurement algorithm, scanner protocol, practicing breathing, uncertainty, there's a pretty big level of uncertainty. And it's influenced by complex interaction of multiple factors. Size of the nodule, complexity of the nodule, location. Is it near the diaphragm? Is it getting vibrated by the heart? These are all things, the type of scanner, the scan parameters. There's just a host of things, even the type of software. And then each of these things interacts with each other. They're not, you just can't look at them individually. There's interaction terms. So this is just an enormously complex topic. Next. Now, for those of you who are fans of movies, this happens to be my favorite movie, and In case you don't know, Wicked is coming out in the next few weeks. But this scene, because this movie has an allegory for all aspects of life, including CT scan manufacturers. Remember when this
Ignore the man.
pay no attention to the man behind the curtain. I feel a little tongue in cheek. This is what the CT scan manufacturers say to us. They get the image, but they say, pay no attention to what's going on. You got this nice image. What's behind the image? That's a really tricky one. It's a really tricky one. So Kyle, I hope I answered why I had that slide. Next. And this is, when I saw it for real, just what happens, this is the Rick's famous Scotch tape calibration device from the center of the field of view out to the periphery. That's identical Scotch tape rolls. Look at how much that distortion is. You can't see that. That doesn't appear on the image in terms of the way that's visible when you're looking at a nodule. So that's one of the things. Next. And there's just a whole host of things. So growth assessment, the optimal time interval for obtaining a follow-up scan depends on the measurement accuracy. The greater the accuracy, the shorter the follow-up time to confidently measure growth. Conversely, if there was no harm in waiting, a longer follow-up time would always be better. Thus, there's a balance between accuracy of measurement and decrease in the prognosis by waiting. That's the balance. And the idea that we're picking 3-month intervals, 6-month intervals, this is, this needs to change. The future will be much more precise, much more quantitative in terms of how we choose when to do follow-up scans. And I think this is where the next major advance in imaging will be. And to do that, we need to understand how much you lose by waiting. If we wait a long time, you'll get the answer. You'll find out if it's cancer if you wait long enough. It's just you may have gone from stage 1 to stage 4, but you'll find out. So the question is when, and every day you wait, you lose something. And the question is, how do you quantify that? And it turns out that we're now at the point where we can start adding that kind of quantification into these models. Next. So as you can see, I'm a big fan of all this growth measurement. Next slide. And for those people that are doing all these biomarkers, everybody's doing a biomarker to say whether something is benign or malignant. There's only one reason that you do that. The only reason you do a biomarker is to save time. Otherwise, you would wait and say, wait 3 months and see if it grows. So to do these biomarker tests, it's just a matter of we're saving that 3 months. And if I need to, and how much benefit are you getting? Well, you're getting the benefit of the loss in prognosis that would take if you waited. You waited 3 months, your prognosis goes down, and that's quantifiable now. And then you have to balance that with how good the test is, the biomarker test, because it's going to have its own false positives and false negatives. So you have to balance the improvement in prognosis against the rate of false positives and false negatives that you get. Next. And this is a Rick slide, but this shows you where it's heading in terms of nodules. On the right is sort of the lowest quality that would still pass in terms of the Kiba criteria. The middle is an average one, and the one all the way on the left is the future. And the future is kind of now. That would be probably what you get with a neotome alpha scan, where you're getting 0.2 millimeter slice thickness and 1024 matrix. So you can see that these will give you better assessments of growth. And so anyway, next. And this was Colin's statement a couple of years later. He was asked to comment on his paper. And I think it was really a wonderful statement, because thinking about where we are with lung nodules now, with all the things that we're looking at, DNA fragmentomics, so many complex blood-based biomarkers that we're using. And this is what he said: in the arena of cancer research, the impact, he's talking about his volumetrics discovery from 1956. The impact was approximately that of a presentation on fire making with two sticks offered at a convention of nuclear physicists. The simplicity of the hypothesis does assault the accepted infinite complexity of etiology, biochemistry, cytokinetics. It doesn't even mention DNA and immunology. But until nuclear physicists solve our energy problem, there is some practical application from the warmth of a small fire kindled with two sticks. I think it was brilliant because to this day, it is still, in my mind, by far the best method of deciding whether a nodule is benign or malignant. It really is. And so it's quite extraordinary. Next. I'm just switching gears for a moment. I only have a couple of slides left. You know, it's not that long ago when you do a blood test and you'd see a room full of people sitting with those counters. They'd smear the blood on a slide and they'd click neutrophil, lymphocyte, granulocyte, and that's how they did it. Now, this is all gone. You don't see people doing that anymore. It's completely automated. And that is the dream for lung cancer screening. Next. Where instead of, you know, here where we put things, there'll be a too low, too high. Next, we're going to have it like this, where we can do this. You'll have all these things looked at, and we'll make measurements. And next, and we'll have a report like this. We'll have heart health, lung health, and we'll have all of these things quantified. And I think this is, in fact, going to be huge in terms of where the progress is going to be with AI. Next. I think every single scan has a heart, as best I know. And this is one of the products that we were talking about that has just gotten FDA breakthrough approval, the idea of looking at the cardiac chambers and measuring it on low dose, non-gated scans where you can measure chamber volume, left ventricular wall thickness, and start getting to the point of predicting who's going to go into AFib in the next 5 years, who's going to go into heart failure in the next 5 years. This is already now basically FDA approved. Not basically, it is, it's FDA approved, this approach for measuring chambers, and then that by itself is going to be used to predict, you know, who's going to have these. And every person that has a scan is going to look at this. Is going to be much more, in my mind, this is actually going to be more important than lung screening. It's going to happen. Next, and here's just another example. I mentioned it earlier. Every person, next, whoops, has a spine, and this has now been FDA approved as DEXA equivalent. And the amount of osteoporosis in this population is extraordinary. And we're now going to start looking at this, and we're going to have to figure out how to integrate this. And yeah, so I think this whole idea of the lung screening moving towards being a health check is where I think the next few years this is going to head. And all these things that we're going to be able to evaluate are coming. And that's it.
Well, thank you, David. So let's see. I heard growth and maybe detect everything you can, or measure everything you can. You were kind of all over it a little bit, right?
Well, growth, I think, is the big area.
Growth is
In terms of the lung cancer, I think growth is where the action is. And how to
Okay.
use that.
All right, so we've got the world according to David. Now we move on to Mario. Mario, you have some slides, right?
Good afternoon, everyone.
Oh, no, we did.
Can you hear me?
Yes.
9 o'clock.
Super.
Yeah.
So thank you for inviting me this year. I'm extremely happy to be online with you. I'd like to be there in person, but geography is not an opinion. So it's not easy to fly over the pond that frequently. I'd like to thank Dr. Yankelevich for his introduction, because actually I'm trying to give you the impression of the point, the point of view I'm starting from with this presentation. And indeed, I'm touching upon the point of the nodule detection that we are performing with AI today, already in the in the long run trial under the principal investigator, Professor Outkirk. So this is the experience where everything came from. If we have 4 reader and we train them to work at their best under their possibility, some of them will be extremely sensitive. Some of them will be extremely specific, probably. And if we take the case of comparing human against AI readers, today we have to accept that indeed AI reader is quite sensitive, but not really specific, because this is the lesson that we taught to AI today. As you will probably see in the chart from Rick in the table, where we were asked to score where we see AI for detection of nodule in the next 5 years. I'm actually scoring a low number because I see that this is done. This is already achieved. We have new perspective for AI, which become a bit more complicated, as David just showed. We can detect extremely small nodules with a 1 millimeter thick CT, and AI is already doing great. So if you take the case scenario under these 4 readers, and reader 2 is indeed AI, you can see that human is failing more than AI for detection, therefore for the negative predictive value. And indeed, the negative predictive value for AI is rated 0.95 over these 283 cases that we ran before the 4 in the lung trial starting. So what's going on now? What's the live prospective use of AI applied in the 4 in the lung run trial here in Europe? Here's what's going on. The data are updated to February 2024 with almost 10,000 CT read. The agreement between the machine working alone and the human and the peripheral reader working alone. So the human reader at each peripheral centers collecting these 10,000 CTs is actually an agreement in 65.5% of cases. Then the 34.5% of cases that had discrepancy between the peripheral and the peripheral human reader and the central AI reader underwent arbitration. And here's what we found, that in almost the 50% of cases, the human central expert reader, so the arbitration by 3 expert chest radiologists, was in agreement with the human peripheral, so we'll still get along as humans. But in 1/5 of cases, almost 1/5 of cases, actually the expert was in agreement with the AI read. And no surprise, there was also a third of the cases where the central arbitration was not in agreement with the AI or the human reader. And this led to a final categorization of over 80% negative cases, actually almost 80% negative cases. And this is another point touched by David in his introduction slides. We want to reduce the burden of exams, and we need time to see growth. So if we can characterize as low risk most of the cases, actually, then we will have a great reduction in the burden of exams and in the burden of reading time and person hours, as you want to call it. So this is the starting point where I'm starting from for the next conversation that we are having with Rick and all the panelists. I think there was not enough time to talk about also other options of AI in my slides. I just wanted to give you an impression of my point of view at the very beginning here. So what I think AI can do today is the nodule detection, and it is a twofold aim, if you want. It can save resources for the reading, but also it can support quality assurance across different centers. This is more or less, this is exactly what we're doing with the 4 in the long run trial currently. So we can overview over several European centers, and we meet every Monday afternoon to review all the CTs from Europe. Not all of them, but just those that were in disagreement between the human reader and the central AI. What AI could do is, of course, get a rating of the cardiovascular risk and the pulmonary non-oncological risk. And I think that the longitudinal characterization that AI can be deployed on is actually the real strength of AI across the 20 years of lung cancer screening with CT for what we are recommending now. And of course, assistant communication, not just for the patient, but also for the healthcare provider, and drive through the guidelines for all the incidental and collateral findings beyond nodule that we see on low dose CT screening. Thank you.
Well, thank you, Mario. So if we could put my slides back up and let first Ella say anything. Ella, I can show your bingo card if you want.
Yeah, that'd be great. And if we'll focus, so far it looks like the conversation is focusing around the lung nodule and the lung nodule detection, but I typed a few things in to just put my thoughts on the screen in context of what has been said so far. So I don't know if it's okay if I share my screen.
Oh, you're sharing your screen?
Is that okay?
Is that okay? Yeah.
And it's really just one slide. And I put it in the context of, I'm a radiologist, but I'm also heavily involved in operations and institutional decision-making as the Chief Clinical Officer for Diagnostics and Clinical Information for our group practice. And so I come at this with different hats on, if you will. And I really like what David focused on originally, which is, it's all about, you find it, it's got a size and you're characterizing, but growth, and how good are we at detecting meaningful growth versus artificial growth or growth that doesn't really exist because of the level of the technology that we have. I really like this concept of what is cancer. We tried to build that into lung rats, meaning every nodule of every size doesn't need to prompt a workup or something invasive, but how much do we really understand in lung what is cancer versus what is a cancer that you need to act on versus a cancer that's a cellular level sitting in a human being that's not going to do anything. And I don't think we've fully explored that or really understand that. How small of a nodule, of what characteristics is it okay to sit and wait at? Or when do you trigger some of these biomarker-based tests to try and move your decision? The quantifying the risk of waiting is fundamentally related to the size, characterization, and growth. And we tend to approach it at the big data level. We aggregate lots of data from large studies, but you're trying to make a decision at an individual level and apply probabilities of a population to an individual. And we're only so far down understanding individual risk. We don't really think about a human being and everything that nodule sits in within that human being. Things like the immune system, their underlying genetics, their age, the impact of diabetes. A lot of these things are much better understood in diseases such as cardiovascular, but they're really not well understood in lung. And so now we have a lung nodule of a size, of a characterization, of a growth rate in a human being, the milieu in which it sits. And we're trying to make a decision about what to do about it. Is it a cancer that you can sit on? Is it a cancer you need to act on? When does that action need to occur? And I always like to come back to the phrase, just because you can doesn't mean you should. Just because you can biopsy a 5-millimeter nodule, just because you can surgically resect a 5-millimeter nodule, doesn't necessarily mean you should. You really need to understand it in the host, the human being. How does the CT data need to be for what we define as what is cancer that's actionable for that desired outcome? And I don't think we really understood that. I think it's important that we get all the way down as far into the detail of what we can do with the technology. But more than likely what happens as you look at the rollout of things operationally and other domains is you push really far, but then you pull back to a point that is clinically meaningful and operationally doable so that you can disseminate the technology. I think there's operational aspects that need to be thought of about AI as we just look at the nodule question, but all aspects of imaging and AI. Yes, there's dissemination of technology and it comes with variations in operations with integration. Are you using the latest software and the latest tools? Or are you sitting on an old version? And how do your patients even know the difference in what you're using? The inherent bias in the data sets that we're training on is real. And there is human perspective on the interaction with the data based on the biases they bring to looking at the images when they're looking at the AI outputs, let alone the quality control of AI tools when they're actually in the clinical domain. And how do you know they're not drifting? A new 2.5 update happens, and all of a sudden the edges of your nodule change a little bit. Who's paying attention? Who's quality controlling those kinds of outputs? And then I think we always have to be cognizant of the medical legal aspects. There's the risk of not detecting cancer. If you say you're going to detect cancer and you expect a certain performance level, there's a risk of not detecting cancer with AI tools. And we find nodules that are not picked up, that are actionable, as we also find nodules that the human didn't identify that are actionable. There are two sides of this. We tend to focus on what the human misses as opposed to what the tool misses. And then there's a risk associated with how is the output actually used or fails to be used in practice? We are simply mere mortals as human beings who interact with imaging data and AI output. And as you know, across clinical practice, there is tremendous heterogeneity of clinical practice, even when you have guidelines that you're trying to get practices to be concordant with. You have heterogeneity of implementation, heterogeneity of use, and misunderstanding of how it's used. So I think we're going in the direction with, yes, finding nodules, characterizing nodules, growth of nodules. I don't think we fully understand what is actionable cancer and how that intersects with the decisions we make on how we treat an individual human being when we have the output of these tools. But I think we're driving in that direction towards understanding it. The operational aspects of AI are very real. And if you ask people in practice, not the kind of people who are presenting at this meeting, who are knowledgeable or attending and listening, but the average practitioner has very little understanding in radiology about what happens when you put in an AI tool. What's the bias? What's the quality control? And what are the points of failure that you need to be cognizant of? So we have a lot from thinking scientifically to do to getting to actually meaningful input. I think we're moving tremendously in this direction, but I think it's the reality of where we need to go. That's all I had.
Thank you, Ellen. So growth will be number one. Is that the way I look at it? Can we, actually, we have a card for you. Do you want to just walk us through why you said sort of, you emphasized risk assessment and detection?
Yeah. So I would say, we have risk assessment tools for lung cancer. They are mostly non-imaging based, but by adding AI to the non-imaging based risk assessment, I think we're pretty close. I think there's other risks that we don't yet measure, and that will become more developed in the future. But I think we're pretty good with non-imaging based risk assessment, and adding imaging based AI risk assessment in combination, I think will really get us there. I think we're pretty good at nodule detection. I gave it an 8 out of 10, but for the reasons that I mentioned, the failure to detect, the users are able to select, for example, you put an AI tool in your practice for lung nodules, you can change the threshold of performance if you want to. Who decides if you're going to detect 4 millimeter nodules or 6 millimeter nodules? Who decides how many nodules you want the tool to detect and when it fails? There's no standards for that yet. Differential diagnosis, if we're just looking at differential diagnosis in a nodule and nodular abnormalities, and I extend that beyond just screening, because we apply nodule detection tools to all of our chest CTs, and there's lots of other diseases that have nodules, and we don't really move down the differential diagnosis. So that's why I rated that low, because we're only thinking about the vacuum of say, screening, where it's more granular. But when you get to all chest CTs and you're applying these kinds of tools, there's a lot of things that can be nodular and they're not lung cancer. I think in therapy, the advances really need to happen to be able to integrate all the patient information. I rated it low because the data is not in the EHR reliably enough to make them yet effective. But I think if you get the data into the EHR, if you get information into it, you can reap the value of all that information in the therapy space. And I think we're making a lot of strides with patient communication in terms of things that have been discussed at this meeting to be able to do a more effective job. I worry about implementation, and that's why I gave it 8 and not a higher number, as implementation, helping people see the value of it and want to put it in their practice and make the choice to do that versus spend money on something else. Those are just the realities of practice. So that's just the nodule column or the lung cancer column.
Well, thank you, Ella. It's interesting, you put a lot of emphasis on lung cancer and cardiovascular, but not so much on COPD until you get to therapy and communication.
Yeah, my reason for doing that is because when we can detect obvious emphysema, when we can, we're pretty good. I mean, emphysema detection is pretty straightforward. But if I look at a lung cancer screening population, the percent that have, say, procedurally actionable emphysema is pretty low. Endobronchial valve treatment, lung volume reduction surgery, those kinds of treatments. And the reason I put a lot of it low is because we miss early disease with the general techniques that are being used across the country in chest CT. We miss low levels of emphysema. We miss the ability to detect airway wall thickening and little bits of mucus plugging when we use 2.5 to 5 millimeter slice thickness in chest CTs across the country. And in lung cancer screening, we still have the ACR practice parameter for lung cancer screening still allows up to 2.5 millimeters, which I think at some point will have to come down if we want to be able to detect the earliest emphysema, the earliest small airway wall thickening mucoid impaction. I also think that we don't know what to do with the data. And there's several studies underway. We're part of one here at the University of Michigan with Milan Han and colleagues. I believe the ALA has funded that is part of looking at people early when they're at Gold 1, Gold 2, Prism, looking at their CTs, looking at their pulmonary function, and seeing what happens over time, because you can find it, what happens with it, and then how are you going to treat it, to have a meaningful outcome. I don't think we're far enough down the question. So that's why it's lower on the risk assessment and perspective. I think once it's actionable, now it's usually at the pretty severe state, unfortunately. But what do we do with early COPD? I think that's a big question still.
That sounds perfectly reasonable. Why don't we give Arjit a chance to describe sort of what his thinking was on our priorities, and how would you spend a couple $100 billion in AI development?
Thank you, and again, thank you for inviting me to be on this panel. Amongst giants, I guess. So I think the detection for the 3 diseases. Well, let me step back. So I just wanted to say, I concur with what my fellow panelists have said and what David has said, and I think one of the largest challenges that we have is the lack of data. It was on David's slide, the ImageNet. It's really surprising how there's a little bit of history about how much having that ImageNet database, which was several million images that were labeled according to what if it's cat, a dog, or whatever. Up until that point, people actually thought like they didn't need to have that much data, and a lot of the AI algorithms were developed with the idea that you can augment the data or do basically tricks to get your data set to improve your performance. But that data set, that image data set, along with other advancements in terms of GPUs and the deep learning, I think are what really set off the whole current AI revolution. And in medicine in general, I think we're missing that kind of large ground-breaking data set. I know at Mount Sinai, for example, we have a lot of trouble every time we want to use data. They think that the administration thinks that they can monetize every piece of data, and you come up with ridiculous numbers when you want to have 100,000 patients. But anyway, so going back to this list, I know we're kind of running out of time for the panel. Risk assessment, I thought was moderate to good opportunity. I think there are definitely opportunities to improve upon our existing risk assessment calculators, which usually use a couple different clinical parameters. I mean, there's definitely opportunities to include imaging as well as kind of analysis of the medical record. Cardiovascular, I gave a slightly lower number than lung cancer and COPD because I think they are perhaps a little bit further ahead in terms of, or I should say, I think the risk assessment tools that exist for cardiovascular are pretty good. I mean, I think compared to lung cancer and COPD at least. Detection, I think, is a good opportunity, great opportunity for all three diseases. I mean, I think, as Mario was saying, reducing the burden on the radiologist is really key. Differential diagnosis, I'm not that I don't see as a really great opportunity, and maybe that is more that. I should say it's more that I don't see much acceptance of that in the next 3 to 5 years. And I think it's for a lot of the reasons that the talk earlier on the large language models. You have issues with hallucinations and things like that. I mean, I think the question for most people is going to be, are you going to trust an AI to make a diagnosis? I think most people wouldn't even, I mean, I don't even trust AI to give me cooking directions. So I'm not going to trust it to, yeah. Therapy, I think, is again a similar issue. I think for better or worse, I think people do want to have that human touch in terms of determining what kind of therapy. I think there is an opportunity, as I think Ella was mentioning, in terms of trying to come up with maybe more personalized therapy that takes into account, more parameters, more personalized information from the patient. And I think finally, for the large language models and patient communication, I think there's an opportunity there, but that's mostly, I think, because it's such a burden to, not that it's a burden, I don't want to say it's a burden to communicate with the patient, but it's a place, I think, where AI can provide a lot of assistance, again, to help reduce the burden on the clinician. Yeah, so
it looks like, well, if we go by row, detection and patient communication are where you put your money. With an emphasis on lung cancer and cardiovascular, maybe. I don't know, it's a little equal, actually.
it's a little, yeah.
But it's interesting, this is a completely different chart than we saw before. So now let's go over to Mario. Mario, you still with us?
Yep, I'm here.
All right, let's take a look at your chart and how would you dominate the AI world with a big team of developers?
So that'd be my point of view. So as I said before, I give it for given that the lung cancer detection is already achieved. So the 6/10 is my point there. So I'm starting with the areas where I would not put money, and is also for differential diagnosis in cardiovascular and COPD. So I'm not really getting what kind of differential diagnosis might be pursued in those areas. Whereas I think differential diagnosis, as David mentioned, mainly with the volume doubling time and improvement of volume doubling time measurement is what we need, what we still need for lung cancer screening with low dose CT. So there, for sure, I would put a bit more money than for detection. Then I think there's couple of things that go along in my thoughts, and those are both for cardiovascular and COPD. And let me imagine this COPD column also including ILA and potential ILD patients in the next 10 years. So this is how I somehow also intended the COPD column. So more about non-oncological diffuse lung disease rather than just COPD. Pardon me if I got it a bit larger than intended, probably. But I think that's an important thing again, because we know that about 1.3, 1.5% of these subjects also might have ILA. So that might be an important slice of the cake also here. So risk assessment, I deem it quite important for both for cardiovascular and COPD. And I was thinking about this risk assessment. I was not thinking about the single time point, but actually as a trajectory in the longitudinal classification of the biomarkers that we might have. Because it's true, as I read in the chat, that cardiologists have many other risk factors, and of course, cholesterol and blood pressure. But it's also true that we see different susceptibility of the organism to those factors. So I think morphology might still be helpful in predicting the trajectory of the cardiovascular risk in a subject of the diffuse lung diseases, including obstructive or restrictive lung diseases in lung cancer screening. And of course, I have to keep lung cancers as a risk assessment target also here. I'm really into optimization of resources. I've been reading CTs in a lung cancer screening trial where CT was administered every 3 years, along with biological sampling of circulating microRNA. And indeed, in that case, with more than 4,000 people, which is still a relatively small number, but can give you an idea, no real diagnostic delay was witnessed. So I think that risk assessment and administering tailored interval low dose CT is still a point in lung cancer screening. Yeah, we've heard that David suggested that even chest CT for resource saving, chest X-ray could be suitable in those countries where resource saving is a real matter. And so if we shade from those countries where chest X-ray could be acceptable to the countries where yearly CT is affordable, probably in the middle we find those countries where a CT every 5 years is more affordable than a yearly CT if it's done safely. So that's my point of view over there, based on the previous experiences.
We have to wrap up quickly soon,
Yep.
so.
And just to mention that for me, cardiovascular and diffuse lung disease risk assessment and therapy were getting exactly along, because I was intending this AI opportunity as a longitudinal tracking of the single individual. And I think I can wrap up here.
Okay, so we're pretty heavy on the risk assessment. You want better tools, right?
Yeah.
But that's not all. Cardiovascular and lung cancer is kind of less emphasized than cardiovascular and COPD. So that's interesting. Now I took the liberty of averaging these numbers. So let's go to that next slide, the last slide.
Equal weights.
Equal weights. No. Yeah, 3 times. Okay, so the average panelist, if you combine, we should have done an AI combination. But anyway, so what it's really not fair because they're really all over and they're justified in many different ways. But I think everybody agrees that patient communication is kind of up there, right? There wasn't a lot of variability on that one. The number one, though, is cardiovascular detection. And Mort will probably be happy to hear about that. So, you know, I'm sure, I guess that meant what, detection of calcifications, of constrictions, of what, go ahead, Mario, explain what you meant by that.
Just a mention, because I was actually answering the table, thinking about what is the biggest trouble when I'm reading lung cancer screening CTs today. I don't have any trouble about nodules, but everything around it, thyroid nodules, axillary lymph nodes, coronary calcification, osteoporosis, metabolic syndrome, those are all cards that we could play on that CT. Lung nodule, I gave it for given. That would be my closing.
Yeah, that makes sense. And it kind of comes out in the average a little bit too.
Yeah, I guess I would just add to that, that while so much has been done in lung nodule, you know, when you get 90 to 95% of the way there, the hardest thing is the last 5% to get it to a place where it's really ready for prime time. And so I think with lung nodules, we're at that like 90, 95% place where you can find nodules with reasonable consistency. You can measure them, you can look at growth. We can do better. We can have to be more consistent if we think about the way things get operationalized clinically. I think that closing the gap, the applications of newer technologies, not just the current state of deep learning. I mean, we need to close that last 5 to 10% to really nail it over the head. Whereas some of the other things, we don't even understand the disease and what to do with it when we find it so early, like some of the early COPD. So how can you have a tool for something which you don't even know what you want to do with yet? So that was kind of my approach.
Yeah. All right, I think we're close to out of time. I just want to throw one crazy idea out. What if I put this chart on LinkedIn and ask the rest of the world what they think?
What would that accomplish?
The discussion.
Well, I mean, to provoke discussion, but you can't deconvolute 4 people. And now you want the rest
I
of the
don't have
world.
enough data.
Oh,
You better build a database then.
get more images.
Good segue. Hi, Susan. Okay, so
It was a layup, Rick. It was a layup.
thank you. Okay, so basically, I think we're all set here. Thank you so much for participating in this, and we'll see you all on LinkedIn, I guess. Bye.